Hello, today I will discuss two articles related to epidural catheter tunneling. The first article focused on a simple 4-step technique for epidural catheter tunneling and explain how the procedure is performed. And the second article examines the clinical benefits of tunneling, including improved catheter fixation and reduced catheter dislodgement. Let's review the key findings for both studies. This article presents a simple 4-step technique for subcutaneous tunneling of epidural catheter. The method aims to improve catheter fixation, reduce accidental dislodgement, and minimize catheter damage while remaining easy to perform in daily clinical practice. Let's start with step 1. After the epidural catheter has been placed, a 14-gauge cannula is inserted subcutaneously from the catheter insertion site to point approximately 3 or 4 centimeters away. The goal is to create the future tunneling pathway while maintaining the position of the epidural catheter. Care must be taken to avoid damaging the catheter during cannula insertion. In step 2, the stylet is removed from the 14-gauge cannula. The toy needle is then advanced through the cannula from the opposite end. This creates a controlled pathway for the tunneling process while maintaining alignment between the insertion and exit site. In step 3, the 14-gauge cannula is removed while the toy needle is left in place. At this stage, the subcutaneous tunnel has already been created and the toy needle now serves as a pathway for the epidural catheter in the next step. In the final step, the epidural catheter is advanced through the toy needle. The catheter is then adjusted to the desired length while ensuring that the appropriate segment remains within the epidural space. Once positioning is confirmed, the toy needle can be carefully removed, completing the tunneling process. The authors applied this technique in 20 patients undergoing thoracic and lumbar epidural analgesia. No catheter dislodgement, catheter sharing, or kinking was reported. Post-operative analgesia was satisfactory with an average pain score below 3. My take-home message is simple. This 4-step tunneling technique appears practical, easy to learn, and use equipment that is readily available in most operating rooms. However, the evidence remains limited. The study includes only 20 patients and lacks a control group. Therefore, this technique should be viewed as an interesting option rather than a current gold standard. Larger comparative studies are still needed. Now the next article. Before discussing the results, let's briefly review the article. This systemic review and meta-analysis was published in 2025 in the Journal of Clinical Medicine by Van Kessel and colleagues. The study evaluated whether tunneling of epidural catheter can reduce catheter migration and infection compared with conventional fixation method. A total of 11 studies involving more than 23,000 patients were included, making this the most comprehensive review currently available on this topic. The authors analyzed 11 studies, including more than 23,000 patients, to evaluate whether tunneling of epidural catheter provide meaningful clinical benefit compared with conventional fixation techniques. The most important finding was that tunneling significantly reduced inward catheter migration. In other words, catheter were less likely to move deeper into the epidural space when a tunneling technique was used. This suggests that tunneling can improve catheter stability and fixation. However, when the authors examined outcomes that matter most in daily clinical practice, the results were less impressive. First, tunneling didn't significantly reduce catheter-related infection. Despite the theoretical advantagement of creating a longer subcutaneous pathway, the overall infection rate was not different from conventional fixation methods. And the second, there was no meaningful improvement in analgesia. Patients did not experience better pain control simply because the catheter has been tunneled. And third, tunneling did not clearly reduce epidural failure rate. Although catheter stability improved, this did not translate into better overall clinical outcome. Based on this finding, the authors conclude that routine tunneling of epidural catheter cannot be recommended for every patient. Instead, the decision should be according to the clinical situation, patient characteristics, and expected duration of epidural analgesia. Finally, my take-home message from this paper is simple. Tunneling may improve catheter stability, but the stability alone does not necessarily improve patient outcome. For watching this Journal Watch episode, if you found this summary useful, please like the video, subscribe to the channel, and share it with your colleagues.